Okay. So I was uh, I was given the topic to discuss about the anatomy of breast and axilla. So my conundrum was what new to add to the anatomy itself. So I decided to keep the topic related to in the era of de-escalation and oncoplasty in breast cancer management, which is the new thing. So I am Dr. Rahul Khubchandani, and I am an assistant professor in Department of Surgical Oncology, Mahatma Gandhi. So the picture that you're seeing on your screen is a sculpture by Michelangelo. He depicted in his sculpture a breast cancer in 1500. Can you see that white spot on the sculpture? So that was one of the few very early depiction of a patient suffering from breast cancer. So these are the three pictures. As you can see, the first one is of the Halsted, the third one is of Mr. Fisher, Dr. Fisher, and the median one is the Halsted mastectomy, in which everything was removed: the breast, the chest wall, the associated lymph nodes, everything. So, introduction: it is the breast is the most commonly operated organ for cosmetic reasons, the third most common, and the most common cancer in females. And the treatment of breast cancer has evolved from radical mastectomies to breast conservation to oncoplastic reconstruction. So now we are incorporating the cosmetic techniques used primarily by plastic surgeons in the oncological framework for the breast cancer management. So how the breast cancer surgery has evolved from an extended radical resections to radical mastectomies to modified radical mastectomies to breast conservation with ALND, segmental resection. And now we are coming to an era of breast conservation with sentinel lymph nodes and altogether eliminating surgeries for primary breast lesion in the era of neoadjuvant therapies. So how has the breast? So this is the scar that we used to have with the Halsted mastectomies. These are the scars of MRM that we routinely proceed. And these are the surgeries that we are performing now these days. As you can see, the breast is completely conserved, it is symmetrical, hardly we can see any incision lines. So radical mastectomies has developed from radical mastectomies to MRM. The primary work was done by Mr. Fisher, and which he showed that the MRM in which we preserved the chest wall and other things had no major benefit over the radical mastectomies. In this another study, he showed that quadrantectomies, segmentectomies, or lumpectomies also had were equally let's say oncologically safe than total mastectomies. And ALND to sentinel lymph nodes, multiple studies have been done, like Alamanang trial, the ACOSOGS trials, and now the SOUND trials, which has shown that we can even eliminate axillary dissection altogether. So the lecture would be have following contents with respect to anatomy and for the discussion's sake. So the breast embryology, the breast developed from a combination of mesenchyme and an ectoderm. The primary breast tissue is developed from the ectoderm, a buddous primary mammary buddous form, which forms secondary mammary growth, and ultimately, by the end of gestation, lacticiferous ducts they connect to the overlying ectoderm, and they are connected to the skin with an NAC, and the mesenchyme forms the surrounding breast tissue. So for us, breast anthropometry and surface markings are very important when we are doing a breast oncoplastic surgeries. So the elements of breast test, it's a three-dimensional structure. So we have a breast footprint, and we have position for an NAC and the breast projection. And we have various points from where we can measure all these things, like the sternal notch, we have mid-clavicular line, the anterior axillary line. So primarily the breast footprint is between the sternum, the anterior axillary line, which is the medial and the lateral boundaries, the inferior mammary crease, IMF fold, which is the inferior, and superiorly it is differs upon patient to patient actually. So like how we measure the breast projections, and primarily we have three let's say measurement that we require for any breast reconstruction. So we need to know what is the ptosis of the breast, which is the projection of NAC below the IMF. Normally it lies above the IMF. So this is the Reynolds classifications for breast ptosis. The other ones are the cup size, which is the difference between the bust and the underbust size of the patient. And taking these two, we can actually decide which reconstruction option after surgery would be best for the patients. So the normal position of the NSE, it is 19 to 21 centimeters from the sternal notch, 7 to 8 centimeters from the inferior mammary crease, 9 to 11 centimeters from the sternum, and 2 centimeters should be the lateral medial crease of the breast. So what is the perfect breast? So no size fits all. It should be symmetrical. Size should be according to the body habitus. It should be confined within the breast borders, teardrop shape with 45% breast volume above the nipple and 55% below the NSE. And the NSE should be adequately placed. So as we all know that the breast lies over the chest wall and it is encased in the superficial fascia between the dermis and the chest wall. And it overlies the chest wall from 2nd to 7th rib between the sternum and the anterior axillary line. And as I said, the upper border of the breast is variable, the lower border of the breast is IMF, and it is connected to the chest wall with suspensory ligaments of the Cooper. And posteriorly from the chest wall, it is separated by a loose areolar tissue, which is called as the in the retromammary space. So as we can all know that the breast is mobile in the lateral side and on the upper side, but it is relatively fixed on the IMF side and on the medial side. So this is the cross section, which is showing the breast over the chest wall. So internally, the breast is formed by a parenchyma and breast lobules, which have 15 to 20 ducts with a lactiferous sinus, which is 5 to 7 openings of the duct at the NSE. And the breast parenchyma, which is formed from the mesenchyme, has lymphatics, arterial supplies, the venous supplies. So arterial supply of the breast now, we come to breast arterial supply, which is important for us. And the pioneering work was done by Jacques Malinac in 1940s. And in his paper, he defined various blood supplies to the breast skin, the NSE, to the breast parenchyma. And as we all know that the breast is supplied from the internal mammary artery perforating branches, lateral thoracic artery, which is also called external mammary artery, thoracoacromial branches, lateral mammary branches, which are the intercostal arteries, and the mammary branches, which is the anterior intercostal arteries. So the vascular anatomy can be divided into 3 parts: the skin, the parenchyma, and the NSE. So all these branches, they form a network of plexus in the subdermal area in the parenchyma, which supplies all these 3 structures. So as we know that we are going into mastectomy plane for doing the MRM, and a subdermal plexus just below the dermis helps us to preserve the overlying skin. Then we have parenchymal branches which are supplying the breast parenchyma. So as we can see that plane of dissection is clearly depicted in the first picture. And in this sagittal cross section, we can see there is a subcutaneous or a subdermal plexus from the similar arteries, and a glandular plexus from the similar artery, and one perforating branches coming from the chest wall to the NSE. We'll discuss about this later, which is called mesentery of the breast. So arterial supply of the overlying skin, if we breach that plane, we'll have that horrifying complication shown in the third picture. The breast skin has gone now, and further this patient developed necrosis, which required debridement. So the blood supply of the NSE, as described in the previous paper mentioned by Malinac. So he described that the NSE is supplied by circular plexus, loop plexus, and the radial plexus. And these are the anastomosis between the left thoracic LTA and the internal mammary artery branches. Maximum supply from the NSE comes from the second and the third perforating branches from the internal mammary artery, and least from in which there is no anastomosis at all. So the mesentery of the breast, this was actually defined by Wuringer. This is also called as the Wuringer septum. So he defined that the breast is suspended by a horizontal septum arising from the 5th intercostal space, and it consists of the vessels and the nerves supplying NSE arising from the thoracoacromial lateral thoracic artery, perforating branches from the 3rd and the 4th intercostal spaces, and it also consists of the nerve supplying the NSE from the lateral cutaneous branch of the 4th intercostal nerve. And this mesentery is attached to the lateral side to the pectoralis minor and the medial side to the sternum. And as the circle showed, if we remove that area, this NSE can be completely mobile on the central pedicle to be shifted anywhere, the up, down, anywhere. So this helps us to do mammoplasty based on a central pedicle. So venous drainage, why it is important is because of METs. So the breast drainage from the axillary drains into the axillary vein, followed which the METs goes to the lungs, and they are also connected via the posterior intercostal veins to the Batson plexus in the vertebra, which is the reason for bony METs. Now we have come to the second part, which is the axillary anatomy. As you can see, the axilla has an anterior border, medial border, lateral border, and the posterior border. The lateral border is formed by the humerus, the posterior border by the teres major, the latissimus dorsi. The medial border is formed by the serratus anterior, the thoracic wall, and the anterior border by the pectoralis minor and the major. So the fascia of the axilla is formed by the clavipectoral fascia, which engulfs the subclavius muscle and the pectoralis minor, and it is pierced by a thoracoacromial artery, which supplies the overlying muscles and medial and lateral pectoral nerves. So what are the contents of the axilla? It is the artery, vein, and some branches from brachial plexus and lymph nodes. So axillary artery, as we all know, has three parts. The first part gives rise to superior thoracic artery, which supplies the upper thorax. The second part gives rise to thoracoacromial artery, which has clavicular, humeral, acromial, and pectoral branches. Pectoral branches supplies the pectoralis major muscle. And the third part gives rise to the subscapular artery, which further gives rise to the thoracodorsal artery, posterior circumflex humeral, and anterior circumflex humeral artery, and continues as the brachial artery. So the axillary vein, it usually follows the drainage of the axilla, and it usually follows the artery, but it is more variable as the veins can also drain into the cephalic vein. So the nerves, three nerves that we usually encounter during an axillary dissection: the nerve to serratus anterior, arising from the 5th, 6th, and the 7th roots of the brachial plexus; the nerve to LD, which is arising from the posterior cord, supplying the LD muscle; and the intercostal brachial nerve, which is a combination of a second intercostal nerve and the medial cutaneous nerve of the arm, and supplying the medial portion of the arm. So the Brecht classified the axillary lymph nodes into three parts: level 1, level 2, and level 3, which is we are very familiar with. So it is based according to its location to pectoralis minor, with level 1 being lateral to the minor, level 2 behind the minor, and level 3 medial to the minor. So, sixth group of lymph nodes that we have been studying: the axillary vein, or the lateral group of lymph nodes along the axillary vein; the external mammillary group of lymph nodes, which is also level 1, it's along the pectoralis minor or LTA pedicles; scapular or subscapular group along the LD pedicle; central group, it is posterior to the pectoralis minor, it is level 2 group of the lymph nodes; subclavicular, level 3, also called as apical, posterior, superior to the pectoralis minor; and interpectoral group, which is anatomically a level 1 lymph nodes, but it directly passes to the central and the subclavicular group of lymph nodes. So in the era of sentinel lymph nodes, Clow et al. Redefined this classification into A, B, C, D. And he based his classification on two structures which are very constant in their anatomy, which is the lateral thoracic vein and intercostobrachial vein. So A is one which is below the intercostal brachial vein and along the LTV. B are the group of lymph nodes which are above the intercostobrachial nerve and along the LTV. C and D are the lateral group of the lymph nodes. So he said that all the tumors along the any quadrant of the breast, so most of them, they are draining either into zone A or zone B, which are the medial group of the lymph nodes. It is about 97%, and the lateral group of the lymph nodes, C might drain in 1.8% and D never drains. So reverse mapping of the axillary lymph nodes have been achieved, have been done to show that there are separate pathways for the lymph nodes which are draining the arm and the lymph nodes which are draining the axilla. So as you can see, the arm lymph nodes, they mostly drain into level D, zone D, and the breast is draining into A and B. So theoretically, we can preserve D and C if we are doing axillary dissection, but the studies have not have shown that it is oncologically not safe to preserve the C and D group of lymph nodes when we are doing an axillary dissection. But in sentinel lymph node, the advantage is these C and D, they are automatically preserved. So the standard axillary lymph node dissection, we have superiorly axillary vein, inferiorly axillary vein. Laterally is the lateral border of the LD and the LD pedicle, and medially the chest wall and up to SA. So do we resect interpectoral group of the lymph nodes? Yes, most of us we do. And what is the evidence? And the chances of involvement of interpectoral group of lymph nodes have been around 7% in both of these Indian studies. And the chances increases if the axilla is positive. It goes up to 22%. So level 3 lymph node dissection, are we doing it routinely? Some surgeons they do and some surgeons they don't. But a large study from TMS showed that the chance of level 3 positivity when greater than 4 lymph nodes are positive and axilla is more than 50%, and up to 1 to 3 lymph nodes, it was more than 22%. So how we are doing sentinel lymph nodes, we are putting in periareolar ICG dye, peritumoral blue dye, axillary incision, minimal dissection, removal of blue and green lymph nodes, and we prefer to remove at least 4 lymph nodes. So this is one of the showing that there is a blue node in the mid picture and a green tissue shown by the ICG, and periareolar incision of putting green dye in periareolar region. And reconstructions options for breast cancer, we have type 1 oncoplasty, type 2 oncoplasty, and whole breast reconstructions. So mostly type 1 is based on dermogranular mobilization. We have Benelli's round block, bat wing, Thyssen mastopexy, matrix rotation plasty, lateral mammoplasty, Grisoti flaps, and transposition flaps. These are few of our patients. In first one, we have the Grisoti. Second one, bat wing mastopexy. Third one is the transposition flaps. The fourth one is the lateral mammoplasty. And we have perforator-based flaps, ICAP, MICAP, LICAP, LTAP, TDAP, etc. So we have intercostal perforator flaps, lateral thoracic artery perforator flaps, and thoracodorsal artery perforator flaps. So there's a concept of triangle of plenty, which is formed by 3 landmarks: lateral breast fold, anterior axillary line, and inframammary fold. And most of these perforators lie in in the triangle of plenty. So anterior intercostal, one of our patients in which tumor and anterior intercostal perforator flap, and we can show the ICG and the perforator, which is clearly visible. Next, this is the final result of that patient. Then we have median intercostal artery perforator flap. Dr. From AIMS has described this. The description is that he has described a no Doppler technique for raising these flaps, especially for an inner quadrant or a central quadrant tumors. This is one of our patients, the LICAP flap. And most of the work in LICAP was done by Dr. Hamdi. And these are thoracodorsal and LTA perforator flaps. The skin pedal can be raised according to these flaps, and these can either be rotated inside the tumor, they can be folded onto themselves. And this is the workhorse of plastic surgery, reduction mammoplasty. And we as oncosurgeons are trying to use these techniques to remove a lot of tumors and at the same time give reduction surgery to the patients. And we are also trying for the opposite side, symmetrization. The take-home message: the planning, anatomy, surgical skill, and to gain that surgical skill, perseverance are various key to lock. That is the surgery. Acknowledgements. Thank you to IASGO and JSF Society and Dr. V.K. Kapoor, teachers who have helped me gain surgical skills and knowledge, and Dr. Rajkamal sir and colleagues from Department of Surgical Knowledge.
So the discussers for this session we have Dr. Rajkamal Kanojiya, sir, is a senior professor and unit head in the Department of General Surgery at Mahatma Gandhi. And we have Dr. Anushree, ma'am, who's an ex-DMH. She's done a great work at breast cancer tumor biology and its correlation in Indian population. She's the associate professor at Department of Radiation Oncology at Shri Ram Cancer Center, Mahatma Gandhi.
Yeah, excellent talk, Dr. Rahul. So actually, this appears very lucrative, and this is only possible because of the deep knowledge of anatomy and arterial supply, which was less understood previously. So if we talk of the Holstedian era, when everything was removed, And our generation even have seen the changes when we turn to MRM. Then we are saying that so mutilating was the Holstead surgery and MRM is best. Then we go for the BCS, then neoadjuvant, again for BCS surgeries, and now these flaps. But in all these procedures, still there is a place for the MRM. Actually, in these procedures, I feel that it is very important to counsel the patient. Counseling is very important because if we only show these videos, then expectation of patient increases. We have to counsel that this is the possibility, follow up, recurrence, everything, or otherwise. So it depends on the patient. So that is an important part, especially for the all junior students. They feel that these are in a select group of patients. You know, these things are possible. This is not a dictum, but that an excellent thing. What we are seeing this in this our era. Previously, what happened in the MRM that we were learned that you have to preserve three structures: axillary vein and nerve to serratus anterior and thoracodorsal nerve. And then also then we came to know that this is the longitudinal branch and it gives branches to the serratus anterior like a pea sensorin. You know, so up to that, if we divide this nerve, then whole of the muscle will be denervatized. So these are the things. So over the years we learned these and hope that these procedures holds very good. But still I say patient counseling is very important. That should be a take-home message, and all the pros and cons of all the procedures should be told because we should not compromise with oncological principle. You are doing great job. So that is a message from my side.
No, but since you have raised this issue for the sake of students who are watching these videos, as of today, what are the situations where MRM would still be indicated?
Sir, MRM can be indicated usually in these all surgeries where radiotherapy is given. First is the if any collagen disorders, those are the absolute indications, multicentricity of the tumor. Second thing, in these all advanced cases, patient have to come for follow-up. If patient is not willing for any follow-up, then we have to go for a single stage surgery, that is MRM. Okay, that depends on the stage size. So that's where comes the role of this thing. Tumor, breast size, all those are relative contraindications. But in the counseling, if patient is willing for follow-up for these all things, is ready for recurrence, ready for any radiotherapy. In BCS, we have to give to radiotherapy to the breast also. Okay. Some patient may not willing. Some patient require that I can only come to your institute only for a while or for 15 days and I'll never come back again. So in those cases, sir, MRM still has a place. That is a standard procedure. And these are all.
Is there a place for a Halsted radical mastectomy today?
As far as I think, no, sir, there is no survival advantage at all. Not at all. Not
What
at all.
about cytoreductive surgery in very advanced tumors, which we sometimes see infiltrating the chest wall and all?
You see, sir, actually, usually surgery is not indicated, but if suppose there is a open ulcers, weeping ulcers are there, then there was a term toilet mastectomy or simple mastectomy just to means give a comfortable life to patient. Otherwise, there is no survival advantage even for that surgery. But we can give that a part of come for the comfort of the patient.
These are the cases where you would use neoadjuvant.
Sir, that is actually chemotherapy adjuvant also. No need for, if it is a stage 4 disease already metastasized, as you said. So I think there is no survival.
No, a
benefit of
locally
surgery.
advanced malignancy.
LABC, yes, sir.
but no
Neoadjuvant, yes,
ulcer.
yes. In
So-
LABCs, yes, there is a role of neoadjuvant chemotherapy. And for that, we can also go for BCS, even LABCs also.
So Anushree, can you please explain to the students what is the role of radiation today, both pre as well as post?
So if
You have a formal presentation?
no, sir.
Okay.
No, sir. So if we are planning for breast conservation surgery, then radiation is a mandatory component of breast conservation protocol. And except for a very few patients who are more than 65 years of age, very small tumor, which are ERPR positive, radiation is a mandatory component. So as a surgeon, what you have to keep in mind is that if you are doing a breast conservation surgery, it is mandatory to put clips on the tumor bed. Otherwise, it is very difficult for the radiation oncologist to boost that area. So what we plan in what we do in BCS is first we give radiation to the entire breast, And after that, we boost the tumor bed. So to identify the tumor bed without the clips, it is very difficult. Then the second point is, if you are doing MRM, then whether if the patient needs adjuvant radiotherapy, if it is T3, T4 tumor or node positive tumor, so we'll plan for adjuvant radiotherapy in such cases. So if you are planning for any reconstruction, then autologous reconstruction is preferred over the implant based, because with implant based reconstruction, radiation causes capsule contracture and the failure rates are very high. The third is axilla. Whether you are doing SLNB or axillary dissection, it has to be clearly mentioned in the notes, because based on that, we have to decide our axillary volumes, whether we have to radiate the axilla or only level 3 and SCF. That will be decided based on whether the node are positive or negative, or whether you have dissected only level 1 or 2 or from level 1 to 3.
So since we have Dr. Suresh also, I'll make use of his presence here. Would you like to give any tips to the young surgeons about protecting these nerves when they are doing a mastectomy?
Thank you, sir, for this opportunity to talk on this topic. So the main aim of in any surgery, the anatomy should be 100%. So that's why this class and this whole conference gives a very good idea to all the surgeons ki how to proceed and how to minimize the complications in any surgery. So as Dr. Rahul describes the anatomy in detail, so the main key of preventing injury to any structure, any vessel, any nerve is the anatomy and its orientation. So your anatomy should be 100%, and your orientation during surgery, your imaginations. You have to imagine when you are dissecting at some point, your imagination should create a three-dimensional image ki what structures are lying behind my cautery tip, behind right, left, anterior, posterior. So that implementation of anatomy should be there during surgery. That gives you a proper idea and proper way of doing and surgery. And you, by using anatomy during surgery, you can prevent the injury to the any, not only nerves, the vessels, the other vital structures.
The other question is that in breast surgery, you rely so heavily on the concept of sentinel node. Now, is there any false negative sentinel node? That sentinel node is negative, but still you will have metastasis?
Yes, there is some, but the percentage is very low. There are chances of false negative sentinel lymph nodes, but they are very low. So we can we have to follow up the patient, and rest of the things. I think if the disease is so minimum to the axilla, the rest of the things can be taken care by the radiotherapy and chemotherapy.
And these interpectoral nodes, which Rahul mentioned, are actually level 1, but are they clinically important?
I think nowadays some surgeons are doing interpectoral because there is very less chances of positivity of interpectoral nodes. So it is not necessary to do the interpectoral if your sentinel lymph node is negative. But if the axilla is positive, it is loaded, then you have to do the interpectoral analysis. Otherwise, I think it is not necessary to the interpectoral to dissect the interpectoral group of lymph nodes.
And if you have a suspicious or a proven positive axillary node, would you go for a full axillary lymph node dissection, or would you do the other option?
It is only full axillary lymph. If it is positive, then you have to do full axillary lymph node dissection.
You cannot leave the nodes and rely on radiation?
No, not.
So if you have done a full axillary lymph node dissection, would you ask the radiotherapist to still irradiate the axilla or no?
No, there is no indication of radiotherapy.
So we do not usually combine both the modalities because the chances of lymphedema are very high.
So which will be the situation where you will irradiate the axilla? Because they are saying if it is positive, they will do ALND and you will not give radiation. If it is negative, nothing is
So
required.
if it is positive and ALND has not been done, then we will give radiation.
If it is positive, then
In some
recommendation.
cases,
If it's
central
some
limb
cases
impact
on
is-
vessels,
No, if it is less than 2 nodes are positive and like it's been done, BCS is being done. So anyhow, the adjuvant radiotherapy is being planned here. So if you
Not to the
fulfill the
ex-
criteria for ECOSOCZ 11 trial, that means there you can avoid doing a complete axillary lymph node dissection. There they will include the
So
extra.
again, I am not a breast.
that is not a practice.
But,
Not
but for the sake of students, is there a situation where you will irradiate the axilla? What are the indications for irradiation of the axilla?
If ALND has been done, the biology is poor and more than 4 lymph nodes are positive. In that case, I think they are doing a regional nodal radiation
But
also
no.
despite an axillary dissection.
But not to the, we are avoiding axilla. Some people give, but
Why?
gamete also.
So students should know
Yes,
why you want to
because the
avoid.
chances of
not a routine
lymphedema
practice.
combining both the modalities are very high. So in renal nodal irradiation, we give RT to
If you
SCF.
left some disease over the vessel, you are not able to remove the studded nodes over the vessel, then I
Node-
think you,
uh-huh,
then you have to
positive.
give the
For students,
RT.
I think NCCN guideline mentions for the poor bandaging and bulky disease, it is recommended, but not mandatory. That is the recommendation that the guidelines give for regional nodal radiation and bulky disease.
One comment I also made, sir, we have to also send a specimen for the prognostic marker like KNSS. It can say, KNSS can evaluate whether the prognosis is bad or good or how much are the chances of recurrence. And even after that, sir, we can decide. If it is less 7% or 10%, for metastatic risk. That's not local radiation.
So Anushree, is there any role for radiotherapy as a palliative measure? We know
Yes,
that
sir.
this
Yes.
surgery cannot offer cure. So what are the situations where you can offer some palliation to the
So in
patient?
metastatic cases where there is a large fungating mass or there is bleeding from the breast mass, then we can offer palliative radiotherapy to the breast. Apart from that, we can give palliative radiotherapy to distant metastatic sites in breast cancer patients.
So that brings me back again to the surgeon. Suppose there is a large tumor infiltrating the chest wall. There is ulceration, there is fungation, there is bleeding. Now we know that we cannot offer cure to this patient. What would be the approach? Would we do a toilet mastectomy first or would we send for radiation, palliative radiation?
It depends ki if the tumor is very big size, ulcer is very big, it bleeds, then our first aim is to give the palliative treatment, and that is the toilet mastectomy, as Dr. Rajkamal already mentioned. In that case, you have to do first toilet mastectomy.
And correct me if I am wrong, but there is a term called axillary lymph node sampling.
Yes.
What is it?
That
What
is the
difference between sentinel node sampling and lymph node dissection?
low axillary dissection is there is a study done by Tata. They proved that it's a low below the intercostobrachial nerve. If you dissect the lymph nodes and that turns out negative, then you can omit the axillary dissection. It is as good as sentinel lymph node biopsy procedure.
But it is little more than sentinel node.
It is little more because you have to dissect all the lymph nodes below the intercostobrachial.
So in this, you don't need to give any dye or any
No.
isotope.
It is the anatomical landmark only.
Coming back to sentinel lymph node. So do you use dye? Do you use isotope or should you use both?
It is recommended to do the dual dye, but in our center we are using ICG.
To preferred is we at least do dual technique, either an ICG or a blue dye with a technetium colloid. So both helps to decrease the false negative rate for a.
What should the students say in the exam?
So they should say dual dye.
So in the recent trials also where they are avoiding SLNB, where they are comparing whether we can omit SLNB also. So they have mandated use of both the techniques.
So if the dual test is negative, then you don't even do SLNB?
No, dual test is for SLNB.
SLNB only.
It is for SLNB.
It is for SLNB.
SLNB by dual.
So
So
Dual
in the
test.
sentinel
comparative
node
arm.
has to be removed. The dual test is
With
to
dual test.
identify the node.
Yes, yes,
Identify.
yes.
But SLNB has to be done.
Yes.
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 Yes. Any other comment from?
So I'll just comment.
Yes,
The
yes.
two auxiliary here, as they mentioned that the zone A, most of the lymph nodes are sentinel are coming at zone A, below the intercostal brachial nerve and along the left thoracic vein. So that is how the study was designed in Tata, that because 87% of the patients of the breast, the sentinel lymph nodes being identified at that zone, that's why they cleared all that zone to avoid the sentinel, because the caveats with the sentinel lymph node is adds on like 1.5 hours to the surgery itself. So we need to remove the node, send it for frozen
And also
section.
logistics. Suppose
Yeah,
I am working in a place where
The
this facility.
aim of the low auxiliary sampling is to minimize the lymphedema, because the lymphatics, mainly the arm lymphatics, are above the intercostal brachial.
No, so what I'm saying, if I am a surgeon working in a setup where I don't have facility for
Then
identification
in
of
that
SLNB or
scenario,
frozen,
low auxiliary
then
dissection is the best.
is the
Is the alternative of the sentinel
If
lymph.
ultrasound shows that axilla is negative, then I should do a sampling. And sampling is not mandatory to have a frozen section.
No,
Yes,
not required.
not mandatory to have a frozen section. If it comes out to be positive at a later time, then we can again go in and do a complete
So
axillary
again,
dissection.
suppose sampling comes as positive, will you go back and do a lymph node
So
dissection or
that-
would you irradiate the
So
axilla?
that trial also has been done. If one node is positive, we can avoid doing an ALNT and go ahead with an RT to that feed. But if it is bulky node, very bad biology, the preferred would be an ALNT followed by a.
Thank you. Thank you very much.
Thank you, everyone. That was a great, interesting discussion. So the next, for the next lecture, we have Dr. Kamal Kishore Lakhera. Sir is a surgical oncologist from Kidwai. Sir is working at the SMS Institute. Uh, he's published a work on thyroid cancers about follicular thyroid neoplasms and its relation with CA125. And his lecture is also on the same. So he'll be discussing about surgical anatomy of thyroid today. As discussers, we have Professor Suresh Singh. Sir is the head of department at SMS, Department of Surgical Oncology. And we have Dr. Pratibha Vyas ma'am. She's a professor at Department of ENT at Mahatma Gandhi Medical College. Over to you, Kamal Kishore Lakhera, sir.
So, good afternoon, everyone. I'm Dr. Kamal Kishore Lakhera, Associate Professor at the Department of Surgical Oncology, SMS Medical College. Today, I've been given the job to talk about the anatomy of the thyroid in relation to the surgery. Especially, I'll talk about the various important surgical aspects, basically the anatomical key zones where we need a deep knowledge to accomplish a successful and the morbidity-free surgery. So I'll describe my talk in terms of the embryological origin of the gland, the various fascias which envelops the gland, the vascular anatomy of the gland, the nerves, the both superior and the recurrent laryngeal nerves, and the parathyroids. And at the last, I think 1 or 2 slides about the radiology of the or the imaging of the gland. So starting with the embryology, how the duct takes its origin during the embryo, like it starts as a thyroglossal tract which descends from the base of tongue, as the starting point is foramen cecum, and it descends in relationship with the hyoid bone to reach its ultimate location in the lower neck. And along that tract, we may find two things. One is the ectopic thyroid tissue, which may lie somewhere between the tongue towards its destination in the neck. Most of the time, it's on the lingual aspect. Another thing is the thyroglossal duct cyst. Okay, as a cancer surgeon, we rarely may see malignancy in the thyroglossal cyst, which is less than 1% of the total thyroglossal cyst, and most of the time it is papillary carcinoma. Okay, and you may suspect it by sudden increase in the size of the cyst, or in imaging, there may be some sort of solid mass within the cyst area with the calcification, because we know that papillary carcinoma of thyroid manifests as presence of calcification in the imaging. And the treatment will be excision, which is, we know that it's the classical cis-trunk surgery, along with removal of the normal thyroid also, plus minus central lymph node dissection, and if needed, the radioiodine treatment. Now coming to the histological anatomy, that's also important because majority of the preoperative diagnosis is based on the FNAC findings. The biopsy is rarely indicated in or not been routinely recommended in thyroid masses. So majority of the diagnosis is made by the FNAC. So we should know that what are the normal follicular cells and the parafollicular cells, because the follicular cells, they give rise to the differentiated thyroid carcinoma, which are the papillary thyroid carcinoma, which we may find it quite easily by their peculiar nuclear features like orphanite nuclei or the nuclear inclusions. Even the parafollicular cells, they may give origin to the medullary carcinoma, which we may find as the amyloid material within the FNAC material, but the problem comes with the follicular neoplasms. So there, because we cannot comment on the vascular invasion or capsular invasion on the FNAC, which will need a proper tissue to designate them as whether they are adenoma or carcinoma. Now we know that it's an butterfly-shaped organ situated in the lower neck front part. This is, we are aware since her childhood, but what we are basically concerned here is the intricate relationship with the tracheolaryngeal axis, okay? Because you know that it overlies the lower part of the larynx and cricoid. The isthmus overlies over the most of the time over the second or third tracheal rings. So this is important because in advanced cases, either the larynx or the trachea, they may get infiltrated. Sometimes even for like non-thyroid lesions, when we are doing the tracheostomy and we need to do a higher tracheostomy, we may need to either retract the thyroid isthmus or we may need to cut it also. Now, the strap muscles, okay, they are the flat muscles in the front of the neck, may be divided as either suprahyoid or infrahyoid strap muscles. In relationship with the thyroid glands, the infrahyoid muscles are more important, okay? And I'll tell you one or two important clinical implications here. If suppose you are being asked, like the MBBS students, most of the time in the Viva, they are being asked that why the thyroid swellings, they don't go above the hyoid bone, okay? Even like larger masses, they may go in deep into the thorax, but they usually don't go above the hyoid. They may answer the region as a gravity, which probably it's partially true. The main reason is the attachment of this muscle. You can see here the attachment of the sternothyroid muscle, okay, to the thyroid cartilage here. So that won't allow the upper pole of the swelling to ascend to above that level because the thyroid lies deep to that plane. One more important aspect here is the most of the time the thyroid the exposure is through the midline incision by lateralizing the strap muscles. Sometimes there is another approach which is called trapdoor approach, where the incision is given lateral to the strap and you medialize the strap to reach that the lateral part of your thyroid gland. Most of the time, I think probably for parathyroid exploration rather than the proper thyroidectomy itself. And third more important point here is after total thyroidectomy or even hemithyroidectomy, we have separated the straps, like we have mobilized the straps from the midline. So there is some sort of potential space anterior to the trachea, and the scar may get adhered with the trachea, which may give an ugly expression of movement of that scar with the deglutition. So it's recommended to again medialize the strap so that the skin scar doesn't come in contact or with the trachea or the pretracheal fascia. Now, this concept of pretracheal fascia is also very important. We know that the deep cervical fascia of the neck, it's been divided into investing layer, pretracheal layer, and prevertebral layer. So the investing layer is investing here these strap muscles after it's taking departure from the sternocleidomastoid. But the important point in relationship with the thyroid is the pretracheal fascia, which envelops the thyroid, and it is basically forming the false capsule of the thyroid gland. And why it's important? Because see, the tissue plane of dissection is between the true capsule and the false capsule. The true capsule is the real membrane-like thing on the thyroid parenchyma itself, which encloses the entire venous plexus. And we, as a surgeon, I think fortunate by this anatomy that the dissection becomes very easy. If we go between the false capsule and the true capsule, the false capsule was formed by the pretracheal fascia. This is in contrast with the prosthetic surgery where the venous plexus lies between the true and false capsule. The false capsule there is the endopelvic fascia. So the dissection is beyond the endopelvic fascia. Here we have got a very beautiful plane, except the area of condensation, which is called the Barry's ligament. Okay. This is the structure which attaches the thyroid gland firmly with the tracheal axis. And that's the region of movement of this gland with the deglutition. So I'll tell you one of the practical tip here. See what happens. There is one or two small tweaks of the vessels which usually traverses through this fascia. And because of the close vicinity with the recurrent laryngeal nerve here, if you over enthusiastically use the energy sources here to control that bleeding, you may inadvertently injure the nerve. So what I do, a small 1 or 2 bursts of bipolar cautery, okay, not too much, keeping the nerve in the vision that it's not too close to the nerve, and then giving a sharp cut by either a scissor or by a knife, so that you get a sudden sense of release of the gland of the trachea, and the rest of the tracheal dissection of like the thyroid dissection of the trachea is a very easy job. Then coming to the vascularity of the gland, it's quite obvious when we have to remove the gland, we have to take care of that. And it's obviously it's a highly vascularized organ because of its endocrinal functions. It senses the metabolic need of the body and releases the thyroxine gland hormone. So it is richly vascular. Even the parathyroids are also one of the very richly vascular organ, though it's quite smaller in size. It gets supply from two main systems, the superior thyroid artery, which is from the external carotid system, and the inferior thyroid artery. The both system has got their own peculiarities. Okay, the superior system is coming straight vertical, dividing most of the time into anterior and posterior branches. So it's easy to control. Okay, you need to take care of the superior laryngeal nerve. Okay, you may either a ligation can be done, a single ligation of the main artery just above the upper pole, or maybe individually the anterior posterior branches depending on the superior laryngeal nerve. But the inferior thyroid artery, it's a quite tortuous course. Okay, it's a sort of horizontal course which goes behind the common carotid artery and then divides into multiple branches, and it has got very complex relationship with parathyroids as well as the recurrent laryngeal nerve. So the older concept of ligating away or for, I think it's all now historical stories like our grandparents used to tell us. Nowadays, in the era of evidence-based medicine, or we can call it surgery, or even the era of artificial intelligence, everything which we can see by our eyes only, that can only be believed. So anything which you have not seen, probably either it's not there or we might have cut it. So that doesn't hold true. You need to individually see the things and ligate. Obviously, when there is a lot of input or the arterial supply, the system has to drain out also. So even the extra pair of veins, which is the middle thyroid vein, probably the first structure when we try to lift up the lobe of the tracheoesophageal groove, we may encounter that. So careful dissection and ligation of the middle thyroid vein is probably the first step when we start mobilizing the gland. And the inferior thyroid veins are also like they are sometimes multiple, maybe pain in the head. Okay, so during the most of the time during the, I think the tracheostomy part, where like emergency tracheostomy, they are the source of bleeding. But like when we are doing an open thyroidectomy, when we have a good exposure, they are not of much of worth. Now, the whole story of thyroid gland surgery revolves around these two things. One is the laryngeal nerve, another is parathyroid. this system of the nerves, they are functionally very important. We know that voice is our own, it's the identity of a person, okay? And but the system is little bit complicated. This is considered to be one of the sort of embryological disaster, or maybe you can call it the embryological anomaly, that the things which can come, which could have come directly straighter, goes too deep into the thorax and comes back. You can imagine that even giraffe, it is almost 5 meter or 15 feet long. Okay, it goes quite deep there. The long neck comes back again to the trachea. But whatever it is, this is how we have to deal with them. So the superior laryngeal nerve gives the internal branch, which is sensory. The external branch is motor to the cricothyroid muscle. The recurrent laryngeal nerve lies deep along the this tracheoesophageal groove and supplies almost all the intrinsic muscles of the larynx. So coming to the superior laryngeal nerve, probably this is the most commonly injured nerve. If we will compare both superior and recurrent, the lesser importance is given to this nerve, because immediately the patients doesn't present with hoarseness. Okay, it is the inability to produce the higher pitch voice. Okay, they probably are not able to scream now. If it's bilateral injury, the voice is really dull. They may have tiredness after a very shorter span of speech. So it has got its own relationship with the artery. That's why the concept of ligating en bloc, it's now no more days there. You need, it is very thin, sometimes may not be seen, sometimes it goes through the inferior constrictor. So most of the time may not be properly seen, but that's why the importance of proper visualization of the upper pole is there, because this is probably the most hidden part of the entire gland. And even if we are not able to visualize this properly, it's advisable to cut the strap, the sternothyroid muscle, rather than struggling there to get in there. Because if you have not seen it and put your right angle artery forceps and en masse ligature has been done, you may get the nerve injured. Now coming to the recurrent laryngeal nerve, it's obviously in the tracheoesophageal groove most of the time, but it's quite variable. Some cases may come to anterior. It has got very complex relationship with the artery itself. It may be, most of the time you'll see in this series, which I have quoted here, though it's not like generalized things, but here you can see most of the time it goes through the different branches, but it may be deeper or it may be superficial to that. So first thing before ligating the arterial branches is to identify the nerve itself. And what I personally believe, that instead of finding the nerve in relationship with the artery, it's advisable you just go a little down there where it's just the trachea and the esophagus. There is no gland there. So in that groove, try to identify the nerve and retrogradely just follow it up where it meets with the branches of the artery. Similarly, it has got its own relationship with the parathyroids. Most of the time, the lower one is anterior, or you can call it ventral. The upper one is posterior. Okay, so and see, if you have to preserve the parathyroids, they need to be taken down. Okay, because the supply, the vascular supply is coming most of the time from the inferior thyroid artery, which I'll show in the next few slides. This is one other problem. Okay, till now we were talking about the recurrent, but sometimes what happens if you have not seen the nerve in the tracheoesophageal groove? This is the possibility which has to be kept in the mind. Most of the time, it is right-sided. See, the irony is, like, we are calling it an embryological disaster, but we are so much tuned that this is the normal anatomy now. But if it takes a straighter course or a logical course, we now consider it as an anomaly, because we are not regular to see directly coming it from the vagus. Okay, so if it's not there in the tracheoesophageal groove, even after extensive dissection, be mindful that it is directly coming from the vagus posterior to the carotid artery. So there, the trick is you can open the carotid sheath, okay, and find the vagus nerve there, posterior to the carotid artery, and gentle dissection of the vagus nerve may land up you giving some of the branch from the vagus which is coming towards the thyroid, which is probably your non-recurrent laryngeal nerve. It is obviously quite rare, less than 1% of the cases. I have seen only once right-sided. Left-sided are usually never seen because they are only with the situs inversus or where there is complete right arterial arch, which is very rare anomaly, and especially we don't see those patients combined with the situs inversus with the thyroid gland anomaly. So most of the time it's on the right side itself. Now, another concept of this organ, okay, this tubercle, this is not a very constant finding, okay. Really, sometimes you may see this sort of outgrowth of the thyroid parenchyma itself, okay, that gives you a hint that the location of superior parathyroid because and the recurrent laryngeal nerve, which is quite deeper to that tubercle of Zuckerkant. Okay, so in I think though it's not a true friend of the surgeon, but sometimes it may help if you see a sort of outgrowth from the posterior uh, border towards the esophageal side. So more of a tongue twister rather than a true friend. Coming to the triangles, okay, I am also not a big fan of remembering all those triangles there. If I start taking the classes, it will be almost half an hour for that only. For recurrent laryngeal now, it's Behr's triangle, Lowry's and Siemens triangle. For the superior laryngeal now, it's the Zoll's triangle. See, the anatomy is of our human body doesn't go in straight lines or circles. So whatever the circles or triangles has been described, they are just to give you a hint that this is a possible area where you need to look the structure carefully. You cannot make that this is 100% a boundary. Just imagine that the Behr's triangle, it may be true for right-sided because the nerve comes from the right subclavian underneath the right subclavian artery. So may take a oblique course. So it may form a sort of triangular structure here. But if you'll imagine on the left side, it's more of a vertical course because it loops around the arch of aorta and comes quite from a deeper plane. So it is more of a horizontal, or sorry, a vertical structure along the trachea rather than coming from lateral aspect. So it can't be a form of triangle. Similarly, a rectangle of which is called the area of danger means this is just to give you an idea that entire things which you are operating lies in that area, which may be either your both arteries, nerve or parathyroid. So anyhow, we have to be careful when you are doing a surgery for that organ.
Dr. Lakhera, about 5 more.
Yes, 2 more slides now, sir. So along with the now the second most important point is the parathyroids. Okay, there are most of the time it's only the 2 glands on each side, superior and inferior. Both are most of the time they are in relationship with the inferior thyroid artery. Okay, and they have got a different texture than the compared to the your central compartment nodes. That's how we can identify them. And no, we have now the availability of other methods like the ICG to identify them. The superior thyroid artery is basically a more obedient thing because it has got a predictive location in relationship with the inferior thyroid artery, almost a centimeter up or down, where it crosses the recurrent laryngeal nerve. The extra thyroidal locations are rare, but for inferior thyroid, parathyroid, it's like a non-obedient student which can go quite well away. Though as per the thyroid surgery, it's helpful for us because if it's not there in our field, but yes, most of the time it is lying at the lower pole of the gland. Now, just one slide regarding the lymph nodes, the central compartment nodes, because they are the first echelon nodes for the thyroid malignancies, which includes the A is pre-laryngeal or Delphian, the B is pretracheal, C and D are paratracheal, which is along the recurrent laryngeal nerve. The rest 2, 3, 4, 5 are lateral group of the nodes. Okay. Then it has got its own relationship with the trachea and the larynx. So in advanced cases, especially if it is too long standing or might have turned into anaplastic, may infiltrate these structures. So the tracheal invasion or laryngeal invasion, if they can be classified depending on these sort of images you can see, and the appropriate surgical action can be taken accordingly. Now the last slides regarding the role of radiology. Most of the time the ultrasound is the preferred modality, which is quite, I think, able to tell us all the possible things. But sometimes in locally advanced cases where you are suspecting or there is a clinical evidence of tracheal invasion, like in this case, or carotid encasement, prevertebral fascia and vision. It's like it's not mobile side to side, even not moving with the deglutition, means it's already frozen in with the prevertebral plane. There definitely the anatomy helps you to delineate the different facial planes. Even the relationship with the esophagus can also be seen here, as well as the evaluation of the various central and lateral compartment nodes can also be made on the basis of the radiology. Thank you so much, sir.
Thank you, Dr. Kamal, for an excellent presentation and all the possible anatomical tips to take care of the thyroid during the surgery and to handle the recurrent laryngeal nerve and parathyroids. Obviously, these are the two more important, very important structures that we have to take care during the thyroid surgery. So, my one question is, what are the different approaches for the recurrent laryngeal nerve to?
Okay, so see, you need to first of all take the gland out of the tracheoesophageal groove by lateral retraction. Then in that groove, uh, one tip is just to go down in the neck and start finding it there. On the left side, it's easier because it's quite close to the trachea. On the right side, it comes almost a centimeter lateral to the trachea and then comes near to the trachea. Then second is the inferior thyroid artery, the various branches of the. Once you have seen the main trunk of the artery, then it comes when it comes closer to the gland there, deep to that plane, or maybe between the branches of that, you can find out the nerve there. Another one was the zucocundal tubercle. If there is an outpouching of the lateral border, deep to that you may see. One more constant finding is there where it goes deep to the ligaments buried there. But anyhow, the best area is when it is away from the gland, so that by your mosquito forceps you can just gently dissect over the nerve.
So
by
basically, you have to dissect first in the virgin area, so away from the tumor, because
Definitely.
tumor may adhere to the nerve, tumor may engulf the nerve. So the main purpose of doing away dissection is to see the nerve in a virgin area, because that is easier to dissect, easy to find out. So in thyroid, the recurrent laryngeal nerve is the main step of thyroid surgery. So you have to first look. Initially, some surgeon says you don't look for the thyroid recurrent laryngeal nerve, but now now the practice is you look the recurrent laryngeal nerve and see and dissect it. Madam.
Sir, generally what happens, we try to dissect the lower pole first, because in books also it is written, if you just dissect the lower pole, ligate it, and then look for the recurrent laryngeal nerve. But what I have found, sir, if we have separated the upper pole first and we have ligated the upper pole first, we just retract it from the trachea and then we look for the recurrent laryngeal nerve in tracheoesophageal groove. It is a very good point to look for the recurrent laryngeal nerve. At the same time, sir has said for the inferior thyroid artery. Inferior thyroid artery, sir, there are 2 or 3 branches. The nerve may be above it, it may be lower to both the branches or in between it. And once the bleeding starts, which is sometimes quite common if we are not dissecting it carefully, it becomes a rather difficult to find the nerve there. So my practice is you just free the upper pole, retract the upper pole from the trachea, laterally pull both the strap muscles and look for the recurrent laryngeal nerve.
Regarding the recurrent laryngeal nerve in relation with the inferior thyroid artery, if you are in a normal size tumor, the subcapsular dissection will taken care all the possible branches to the thyroid.
Sir.
No need to ligate the vessel separately.
Mhm.
If you are right in the subcapsular plane, there is no need to ligate the artery separately.
Certainly,
no
sir.
need to go in that. And another advantage is the nerve never runs in the subcapsular. So
Sir.
that automatically lateralize the nerve.
Sure, sir.
I am talking about the advanced cases when the tumor is in the thyroid lobe and it is abutting the nerve. Then you have to enter at the lower pole first. You dissect in the virgin area and then go cranially.
It will get the excellent
Really,
results.
it is not
sir.
further thing.
So again, for the benefit of students, what will be the situations or indications for resecting the nerve? And if you have to resect or if you have injured, what about repairing or reconstructing it?
Yes, sir. Like the most important aspect is preoperatively identifying the nerve involvement. If the nerve is already been infiltrated, there is a known mobility of that ipsilateral vocal cord, then it has to be resected. There is no fun of saving that now once it's already been infiltrated. But the problem comes in.
But can pressure alone cause that?
If it is going through the tumor, then definitely it is infiltrated. Yes, pressure can cause neuropraxia. So that decision has to be made intraoperatively. If we see that you are able to separate the nerve out of the actually the capsule of the tumor, then it's okay. If it is through the tumor and it's already been compromised, then it can be resected. It has to be.
Your practice, ma'am.
Sir, generally, infiltration of recurrent laryngeal nerve, I haven't seen the infiltration into the nerve, but yes, sometimes it is quite entrapped into the tumor, and it is really very difficult how to identify the nerve with all the bleeding and all. So there might be some chances of injury to the recurrent laryngeal nerve, but knowingly we should resect it. I haven't come across some case.
My practice is to save the recurrent laryngeal nerve in any condition. Never resect the recurrent laryngeal nerve. It may, because the residual disease will taken care by the radioiodine. So try to save the nerve. I think I am right, Dr. Ganesh.
Routine practice is to save the
nerve.
Even if it is
if patient is having voice change, then we have to resect the nerve and re-anastomose. If there is no any voice change, then even microscopic disease will be there.
Will taken
it will be taken care by radioiodine.
So the vocal cord is fixed. Okay, the nerve has going through the tumor, then probably it may not help. But yes, if the vocal cords are mobile and during some sort of manipulation during the surgery, if you can get out of the tumor, then it's advisable.
Okay, the second situation is, okay, I'm operating for a benign disease and accidentally I have cut the nerve. What should I do? Recurrent laryngeal.
Unilateral or bilateral, it depends.
Okay, both.
So for unilateral, for both, if bilateral there is injury, you have to be anastomosis should be done by microscope or loop.
Sir, we have done, sir, it. Yeah, we have twice re-anastomosed the nerve because during the surgery we got to know that yes, nerve has been resected because it was just quite adherent to the tumor, and we re-anastomosed with 10-0, sir.
Yeah, but most of these injuries will occur in a place where there is no operating microscope. I may not have been in a loop. So what do you recommend? What do you suggest?
Tracheostomy is the remedy for the bilateral recurrent laryngeal nerve injury. And if it is, so there should be a rule while extubating the patient, anesthetist should see the vocal cords because bilateral neuropraxia may also leads into severe respiratory distress. Even if you are not cutting the nerve, the neuropraxia may lead to this severe respiratory distress. So in that case also you need to do a tracheostomy. So tracheostomy is a remedy for the bilateral recurrent laryngeal nerve injury as well as neuropraxia.
There should be some anticipation by surgeon also. Yes, there might be some chances to injury to recurrent. So we can tell our anesthesia colleagues ki yes, go.
I think it should be a routine practice to see the recurrent vocal cords in each and every patient after during extubation.
Okay, Dr. Lakhera, two questions from students' point of view. which are the situations where you would recommend a preoperative CT or MRI? And if imaging, then which one, CT or MRI? What are the clinical situations?
So clinical situation in the large advanced cases where either you are expecting the regional spread of the disease to either larynx, trachea, esophagus, or carotids. So one situation is that most of the time it's in the malignant situations. Another is the extent of the retrosternal goiter. Okay, and sometimes even when there are large nodes in the lateral compartment, we may, or in the central compartment, we may have the superior mediastinal nodes. For that also, we need imaging for the, at least the upper thorax.
In which imaging you?
Both CT and MRI are equivalent, but we usually practice getting a CT scan done, which is easier to interpret.
So in the scenario of a benign large multinodular goiter, the only indication would be a retrosternal
goiter.
extension. And any tips for identifying, you mentioned several points, but any tips for identifying the parathyroids other than the color, situation and all, anything else?
Yes, sir, the location and color. And see, the confusion occurs either it is a fat globule or a lymph node. So anything which is like oval or something in that shape of the parathyroid, a flat organ, which may be either a fat globule or a node, a slight manipulation of that structure, if changes color, it becomes aggressive, it becomes more darker in color, more vascular in color. Most of the time it is parathyroid. Okay, the nodes or fat, they usually don't change their colors. And if you have inadvertently taken out and now you are expecting you have taken out parathyroids, then you have different options. Floating test there or getting it frozen section is also an option.
And one thing more, sir, I want to add. We recently experienced it. Only Friday, we were operating a huge multinodular goiter with the left lower parathyroid adenoma. Sir, it was a huge multinodular goiter right from the clavicle and both the upper lobe poles of the lobe are going up to the mandible. When we removed the gland, we thought that all the parathyroids have come out, but PTH level was not lower down. We searched and searched for the parathyroid gland, but it was all in vain. Then we injected IV methylene blue after the hypersensitivity test. It is in the dose of 5 mg per kg of body weight. The color of parathyroids, especially if there is abnormal parathyroid tissue, it becomes darkened. It becomes dark blue. So that parathyroid adenoma, it was below the clavicle. And we called Dr. Dinesh Yadav and he was very much of help. He sent Dr. Rahul Gupta for that parathyroid adenoma because the upper pole of parathyroid adenoma, it is visible. It was up to the upper level of clavicle, but whole of it, it was below the clavicle, sir. What you have said, thyrothymic tract in the
go deep into the thyroid.
28%,
Was
sir.
disobedient parathyroid, like many of the students today.
It is a very good technique to give IV methylene blue.
Even ICG can also be used if you have the infrared camera.
For such huge glands, did you ever encounter tracheomalacia and tracheostomy required?
Not yet. But yes, it is written there and it is, sometimes it happens, but not yet.
So your take on IONM?
Yes, maybe I think in the recurrent settings. Okay, like we have already someone, maybe us or someone has already operated and there is a recurrence in the tracheoesophageal groove, maybe a central compartment nodal recurrence or something, then definitely it's an help there because there is a previous surgical fibrosis and scarring. But as a routine in a obviously in a non-malignant cases it doesn't help much. In malignancy, if it is advanced, imaging is showing that deep infiltration to tracheoesophageal groove, there you may take help if the nerve is not clinically pre-involved there. Otherwise, I think the best indication is a recurrent setting surgery.
So just a small point, like you've mentioned, you've written a book about 8 to 0 of safe cholecystectomy. I think there should
Safe
be a
thyroidectomy.
safe thyroidectomy. It has to be that. Definitely there has to be a book for 8 to 0.
Why would be the spelling of thyroid? So you people are, yeah, I fully agree with him that we should probably write a book on safe thyroidectomy, definitely.
It's actually such a common procedure happening in multiple settings. I think we could do a to
अब
Z.
usually ऐसे
safe
cases में
type.
ये होता है कि the person who suggests has to do it, so you do it with the help of all the senior colleagues. Yes, you start the process. Yeah.
So thank you so much for the interesting discussion. For the next session, we have Dr. Manish Jain sir joining us online. He's a senior professor in the Department of Microvascular and Oncoplasty Surgery with us here at Shri Ram Cancer Center in Mahatma Gandhi Medical College. So sir, हमारे PMMC है, like he's the workhorse for us for our all oral head and neck reconstruction. I welcome you, sir. The topic for the session is surgical anatomy of flaps. As discussers, we have Professor Dinesh Yadav, sir. He is a very senior professor and ex-alumni of GCRI. He's the professor and head at Shri Ram Cancer Center at Department of Surgical Oncology and my mentor today. He's done pioneering work in head and neck surgeries. His work at PET, being the initial investigation for larynx and tongue, is also exceptional. We have another discusser today as Professor Sanjay Sharma, who's again my mentor here at Department of Surgical Oncology, Shri Ram Cancer Center, Mahatma Gandhi. But he'll be joining us online. I welcome you, Sanjay sir, Manish sir, and Dinesh sir. Over to Manish sir for
Thank you,
his presentation.
Yes, Manish, आप share करो अपना presentation.
Sir, yes, sir. प्रेजेंटेशन शेयर कर दें सर, आ रहा है सर?
अभी नहीं.
स्क्रीन शेयर लोड सर.
आप अपना video camera off कर दो because I think your connectivity is not very good. Then you will be able to share. Now we can see. Go on the full screen mode.
Yes, sir.
Yes.
Full screen mode, sir.
Please start. Please start.
Yes, sir. Thank you, sir, for inviting me for this JSF conclave. And my topic is flap anatomy. So I'm just discussing the basic flap anatomy of flaps. So why we need flaps reconstruction? So the difference between the flap and graft. Graft we don't have any.
Your slides are not changing,
Manish.
Manish, your slides are not changing.
Sir, it's loading, sir. It's loading.
हाँ तो आप अपना
Yes, sir.
वीडियो कैमरा ऑफ कर दो. Keep only your microphone on.
Sir, वीडियो कर sir. Yes, sir. Sir, अब आ रहा है sir?
Yes, now we can see why. Yes.
Yes, sir. So because there is difference between flap and graft. In flap, we have inherent blood supply. So we can use it to cover any vascular structure or any unvascularized bed. So flap need, because for covering the vital structure, for padding bony prominence, chronic wound, reconstruction of the any full thickness defect after cancer surgery, like we usually routinely do in the head and neck cancer. And obviously the flap have better aesthetic result compared to graft. So what is the flap? Flap is a unit of tissue which have its own blood supply when we are transferred from the donor to the recipient side. These are the basic definition of the flap. And we are classified flap according to the many classifications they are present, but the most common classification is 5C, in which we classify flap according to circulation, according to the tissue composition, according to the movements, contour, and condition. They are the most well accepted classification for the flap, and we are classifying flap on this classification. So this is the main overview. Another classification form location like regional flap, local flap, or distant free flaps, attachment pedicle flap or free flaps, according to the perfusion, random pattern, axial pattern, or any perforator base flap. any special features like tube flaps, retrograde, supercharged flap, and we are doing supercharged like in breast reconstruction. And according to the movements is rotational, transposition, and advancement flap. These are the one of overview of the classification of the flap. So before going through that, we first understand the basic anatomy of flap. As we know, there regional artery traverse in all over the part. So there basic many perforators, many branches traverse. One through the septum is the septocutaneous artery. If it traverses through the muscles, it is the muscles, so it is a musculocutaneous artery. Then after this, they are piercing the fascia, like especially in the limb, upper limb and lower limb. There is well-defined fascia as compared to the torso, like over the abdomen and the back, which is there is less defined fascia. So it's traveling the fascia and from the prefacial plexus, which is the main blood supply of the fascia. Then it's traversed through the tissue, fat, and make many subdermal plexus here before the dermis and the dermal plexus. So for any flap, the basic main important plexus is the subdermal plexus and the prefacial plexus. The prefacial plexus is important when we are taking fascia along with the flap, and subdermal is when we are harvesting flap as a skin flap. So subdermal plexus is very important, and it is main blood supply to the skin flap. And this is another picture showing the clearly. This is a parent vessels, and this is a direct cutaneous perforator going like in the deltopectoral flap. There is direct cutaneous perforator, so it is skin flaps. And so if we are taking muscle, it's traversing through the muscles, that musculocutaneous and the septum, well-defined septum in the limb, especially. This is a septocutaneous perforator, which is a direct septocutaneous perforator. This is a deep fascia, and it's make plexus in septum and the fascia here, prefacial plexus. So there is one of the important concept is angiosomes concept. It is like previously we are this is a new concept in which we harvesting the whole of the tissue, whole composite tissue like skin and the whole tissue on a single source vessels. So this is an angiosome concept, and about there 40 angiosomes are present in all over the body and depend on the parent vessels, which vessels supplying. So this is a diagram showing the angiosome concept, like diaphragm, ALT flaps, every flap is based on their name source vessels. So this is one of the classifications of flap, as I already discussed, according to the local flaps like rhomboid, gyroplasty, bilobe flaps, regional flap like LD flap for the breast reconstruction, pectoris major flaps for the head and neck reconstruction. Distant flap either can be used as a tube flap or the free flaps. Free flaps, the microvascular procedure required to anastomosis artery and vein to maintain the circulation of that flap. And rotational flaps usually we are using in the scalp reconstruction, advancement flap in the over the face like VY advancement flaps. Interposition flap used when there is intact skin tissue island between the defect and the flap donor site. Transposition flap we usually use in the limb reconstruction like trauma in the lower limb, in which we are using transposition flap. On pattern of the blood supply, I already discussed the axial pattern and random pattern. Like I already told you, random pattern flap main blood supply is the subdermal plexus. Axial pattern flaps are flaps in which there is named blood supply, which run along the longitudinal axis of the flap. Like radial forearm flaps are the axial pattern flaps. According to tissue composition, we can divide the flaps according to cutaneous flap, in which there is only the skin, like fasciocutaneous flap, in which there is skin along with the fascia, musculocutaneous skin and muscles, and the osteocutaneous, in which there is muscle, skin, and the bone is also the compositions. This is another slide showing the classification of the flap: random pattern, axial pattern, perforator base. This is a new concept of the perforator base flap, in which a perforator which arises from the source vessels traverse through the muscles or septum to supply a part of the skin, like based on the angiosome concept. So this is a perforator base flap, which is most commonly used. We are using in our head and neck reconstruction. So this is a vascular classification and the random pattern flap based on the subdermal plexus, and we can harvest up to the safe ratio is the 1:1, but on the face we can harvest up to the 5:1 ratio, length and width ratio, the random pattern flap, because of the very good blood supply over the face. And this can be based on method of the transfer like advancement, rotation, transposition, island flap, according to the shape gyrplasty, which commonly used in the scar revision gyrplasty, rhomboid flap, the Limburg flap. So this is the another classification of the advancement flap, in which we advance the flap. So this is advancement flap. We can harvest up to the length of to breadth ratio is 1:2. Rotational flap, in which the primary side can be closed primarily or with the skin graft, and transposition flap, in which secondary defect always closed with the skin graft. These are basic flaps which we teach our postgraduate student for during the training. So this is a slide showing the rectangular advancement flap, in which this is a defect. We can advance flap based on the single pedicle here. And if there is some, we are not able to achieve, reach movements, then we can use that burrow triangles, so that it can safely reach up to the defect. This is another VY advancement flap, which we most commonly use in our patient with the post-bone contracture or any fingertip defect, in which we use VY advancement flap, in which it's based on the supply on the subdermal subcutaneous pedicle. This is another case in which we use local rotational flap for the closure of the defect. We can see the primary defect, secondary defect closed primarily. This is a transposition flaps, in which we can, this is a defect, we can mark the flap according to defect. We make first triangulate the defect, and then we plan this triangular flaps. And then we transpose that flap over the primary defect. This is the area secondary defect, which we use usually with skin graft. This is a bilobe flap, most commonly used over the defect over the nose, in which we two flap we use. One flap is used to cover the defect, and second flap is used to cover the defect which formed by the primary flaps. So this is a very commonly used flap over the nasal defect. Gyrplasty is one of the most common procedures in the plastic surgery. Gyrplasty is also a base of transposition flap, in which we use two triangular flaps which transport to each other. So it's lengthen the area, especially in the patient come with the linear contracture. This is a very commonly used procedure in our plastic surgery, and in which the three limb of the gyre must be equal length. Like I will show you in the slide later. And the most commonly angle which we use is 60 degrees, so that effectively 75% of the length we can achieve length to break the scar. So this is the another Limburg flap, in which we defect rhomboid shape, and then we make two triangle 120 degree and 60 degree. So this is a short axis in which we plan the Limburg flap. The distance of B and D, D dash is equal to the D and E. So this is a Limburg flap. We transpose this Limburg over the defect, and the donor side closed primarily. And most commonly used flaps in our cases, especially over the face and torso. So what is axial pattern flap? I already told, the flap with a direct named blood vessels which run along the longitudinal axis of the flap, like ulnar artery, radial artery, forearm flaps. They are most commonly used flaps in head and neck reconstruction. So this is one of the flap is nasolabial flap, in which we use named angular vessels based on angular vessels to cover the defect. One of the reverse flow axial pattern flap. This is a commonly used flap, but it is a severe flap, especially in the foot reconstruction, where we use the axial pattern not from the direct flow, but in the retrograde flow of blood coming from the arch to the flap. So it is reverse flow axial pattern flap, like in the medial plantar flap, in which the medial plantar artery, which is a branch of the posterior tibial artery supply, but we clip it is proximally, so blood supply is maintained through the retrograde flow, like from the lateral plantar vessel and the arch, like plantar arch, and if that we use in the hand, so there is palmar arch, in which we can harvest the radial artery flap on the reverse flow also. So this is a reverse flow axial pattern flaps. So this is another classification of the flap according to the composition. Skin flap, as I told you, the skin flap composed of skin only with some superficial fascia, fasciocutaneous flap with the skin fascia and the deep fascia. There are two fascia. One is the superficial fascia, scarpa fascia, and deep fascia, which is well defined in the limb extremity. And myocutaneous flap include the skin, fat, and muscles, and the osteomyocutaneous flap including the skin, muscles, and the bone. Especially we are using fibula flap in our head and neck reconstruction, the osteomyocutaneous flaps. Perforator flap, this is a new design concept in the flap reconstruction plastic surgery, in which there is single perforator which arises from the source vessel supply the skin and the any composite of tissue like skin, muscles, fascia, and the bone. So this is a perforator flap. So perforator can be passed from the skin from the source vessel to the skin through direct or through the musculocutaneous and subcutaneous route. So this is a perforator flaps classified into a different kind, like muscle perforator, myocutaneous perforator flaps, as we are doing in the ALT flap, which is a myocutaneous perforator flap. In ALT, there is also a subcutaneous perforator flaps, in which the septum between the rectus femoris and vartus lateralis is traversing through the this septum, the subcutaneous perforator flaps, and the direct cutaneous perforator flaps, like SCIP flap. There are many skin flap in with the direct cutaneous perforator. So perforator flap can be named according to the nutrient vessel, like deep inferior epigastric perforator flap, which we use in the breast reconstruction, and like depend on the area from the anatomical region, like LT flap, in which there are multiple perforators. So we call that flap according to the anatomical region, anterolateral flaps. So this is a case in which we reconstruct the breast with the diaphragm flaps based on the deep epigastric vessels. And another is muscle myocutaneous flaps. So they can be muscle most commonly used in the trauma reconstruction. So it can be pedicle flap or at the free flaps. So I already told you myocutaneous flap composed of the skin and the muscles and with dominant vascular blood supply, and most commonly used in the breast reconstruction, head and neck, and a trauma. So this is various classification of the muscle flap, in which we divided the type 5, in which is in the type 1 there is single dominant vascular pedicle, like cancer. There are multiple type there, the dominant, and this is dominant vascular pedicle, this minor pedicle. Flap can survive on this pedicle only, and flap cannot be survive on minor pedicle. So gracilis is a type 2. Type 3, dominant vascular pedicle, like gluteus maximus and the L flap, in which there is thoracodorsal is one dominant, and the perforator from the intercostal artery, the second dominant perforator. Type 4 is the multiple segmental vascular pedicle, like in the sartorius. So this is very unreliable flap, because we are not, the vessels are not reliable. And type 5 is the one dominant segmental vascular pedicle, like in the latimus or petrolus major flap. So including the donor recipient side are not close to one another. So we are always at a distant flap, like cross leg flap, in which we use flap on the leg another leg. So this is cross leg flap. Groin flap is one of the most commonly used flap, in which we from one region and used to defect over the hand. So this is distant flap, and if we are not able to close the means approximator, so we can use the distant flap as tube flap and the free flap. This tube flap is a very common concept in 1950, in which we want to reconstruct the over the face. So why do we use groin flap? First, we transfer that groin flap over the forearm. Then from the forearm to the face to reconstruction the defect. So it is a multi-stage procedure. So to avoid these, it will take long time. So we now use microvascular free tissue transfer, in which we transfer the tissue from the one part of the body to another part with pedicle, which consists of the artery and vein, and we anastomosis that artery and vein to the recipient side, so that maintain the blood flow into the tissue. So it is microvascular free tissue transfer. So thank you, sir. This is a basic anatomic of flaps.
Dr. Sanjay, you can maybe put your camera and microphone on. Camera also you can put on. Yes.
Thank you, sir. Thank you, Dr. Manish. You have presented almost all of the
Manish, you can stop sharing.
Yes, sir.
Thank you, Kapoor sir, for giving the opportunity. And Dr. Manish has presented almost all the basic anatomy for the flaps. And what we are doing, he has helped us a lot to cover the big defects. He's doing perforator based flaps. Initially, we were doing, before Dr. Manish has come, we were doing pectoralis major myoclonus, which is the workhorse. But nowadays, mostly we are doing microvascular flaps in the patients. Thank you. Thank you, Dr. Manish.
Thank you, sir. Thank you.
Thank you, Dr. Manish, for this crisp and nice presentation. For student purpose, grossly the flaps are divided into local flap, regional flap, and free flaps. So local flaps is for to convert the tension point from one side to another side. It's basically you convert that tension point into less tension points. Regional flaps are for that areas in which you are not able to use local flaps. And free flap is now the workhorse of reconstruction. So, Dr. Manish, what is the basic advantage of doing free flap over these regional flaps?
Actually, regional flap, free flap, we can customize free flap according to the defect. Like if we just want to take fascia, want to take only the muscles, we can customize flap according to the defect. But it is not possible with regional flap. And with regional flap, with free flap, they are all on phenomena. Either flap will survive completely or gone. But in the regional flap, the chance of the distal necrosis are there. And obviously, in the form of the donor side, mobility is less with the free flap as compared to the regional flap. So there are many advantages of the free flap over the regional flap.
One question from my side. Dr. Manish, what would you like to say for regarding the preparation of the vessels which you need, like facial vessels? What precaution we should take so that the flap may not be have any problem in post-op?
Preparation of the vessels actually is we need to first prepare vessel by removing adventitia because it is a thrombogen.
No, from our point of view, because we are dissecting the glands.
Don't do more traction. Sometimes traction when we we separate when we are doing in the second B dissection, so we can when we separating it from the submandibular gland, so we put more traction, so it may damage the blood vessels, facial vessels. So we avoid traction while doing dissections. And enough pedicle length. Pedicle length also gives sufficient length so that we can anastomosis to its vessels without tension.
Sometimes we are using the contralateral vessels because on the same side in recurrent cases, facial vessels and they are being already used. So we are using opposite sides. So what
Yes.
would, for student point of view, what would you like to say how to preserve the opposite side vessels? At what level we need to preserve those vessels?
When we are doing anastomosis on the opposite neck, then we need sometime it not we are not sure when if we are harvesting ALT flap, we are able to achieve good pedicle length. So always try to preserve as maximum possible of vessels in the opposite side, especially vein. When because when you are doing so, you are always concentrate on the artery only, not vein. But vein is also as important as artery because one is giving flow and one is taking the blood flow out from the from the flap. So vein is also very important. Whatever the caliber, always save vein along with the artery.
You need at the angle.
I think it's better to dissect up to the angle of lip. And then that's length of the vessel is sufficient because it reach when we separate it reach up to the midline. So it's easy for us to do anastomosis when we are doing anastomosis to opposite side.
Okay, thank you.
So, Dr. Manish, what is your take on CAD and biohazard patients regarding free flap or regional flap or local flap?
CAD, sorry, sir.
Coronary artery disease and biohazard patients.
Coronary artery disease means atherosclerotic vessels.
Atherosclerotic vessels, and in biohazard patients, whether you prefer free flaps or regional flaps for reconstruction.
As such, in the basically previously when I starting practice, that time I always have fear of doing free flap in the atherosclerotic, especially in the old age patient. But with the experience, I can say that until unless there total blockage of the artery, we can safely do an free flap reconstruction in the atherosclerotic patient also. But there is some careful we take care while dissecting the vessels. Do not over dissect vessels or do not use clamp. In the atherosclerotic vessels, we use needle from inside to out so that it not dislodge the plaque. And mostly out of 10 cases in my experience, in the 9 patient flap work well in atherosclerotic vessels also. And in the biohazard like HbSAg and HIV positive patient, I think it's safer to do free flap as compared to regional flap, because with all these advanced techniques, the bleeding is less with the when we are harvesting free flaps, and the time is almost equal to as compared to the regional flap, and the chance of success is more in the free flap, so that patient there is less chance to the reoperate patient if there is in these biohazard patients. So first try is the best try in my opinion. So always try to do free flaps. Because in regional flap there is wound adhesions and many other things. So maybe most of the time we take patient again in the procedure room to do secondary suturing or to treat the wound adhesions. So I think free flap is better choice.
Thanks for Dr. Manish for insightful comments. Now it's a handover to Kapoor sir.
Thank you, Manish. Thank you, Dr. Dinesh, Dr. Sanjay. So with that, we come to the end of the 5th JSF, and I would like to take this opportunity to thank my support team, which has been here throughout the day, the student volunteers who were timekeeping, so that is why we could start and finish in time, faculty from my own institution, especially faculty from other departments, and faculty from the city of Jaipur and rest of the country. We would also like to put on record the permission of the International Association of Surgeons, Gastroenterologists and Oncologists for conducting this, as well as all the previous 4 Jaipur surgical festivals under their auspices. And I'm grateful to the management of my institution for providing all the support. And thanks to almost 300 delegates, including 80 from countries outside India, including Cambodia, Cameroon, China, Ethiopia, Hungary, Indonesia, Ireland, Kenya, Kyrgyzstan, Malaysia, Maldives, Moldova, Myanmar, Nepal, Pakistan, Peru, Qatar, Senegal, South Africa, Sri Lanka, and Tanzania. So thank you all very much. And as we announced earlier, all these videos have already been uploaded both on University YouTube channel as well as Gastro University YouTube channel. So those of you who missed these videos, you can watch them. The 6th JSF will be held during the first weekend of December in 2026. And most probably the theme will be errors in surgery, not complications, errors in surgery, errors of commission. So I will request all my senior faculty colleagues to admit in public what mistakes they have done during their career, what was the reason for it, how it could have been avoided, and most importantly, how you can avoid it in future. So see you all next year in December. Thank you very much.
Thank you, sir. Thank you, sir.
We'll have a group photograph, and then if you wait for a minute, I'll have a group photograph with my team also.